are in listen-only mode.
Good evening, everyone, and welcome to tonight's webinar presented by Dr. Bryann Bromley. After tonight's presentation, participants should be able to recognize the importance of a systematic fetal anatomic evaluation in the first trimester and appreciate the natural history and limitations of first trimester anatomic imaging. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this educational activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Dr. Bromley has no disclosures. AIUM staff members and individuals involved with planning this activity have no disclosures. During tonight's presentation, if you have questions for the presenter, you may submit them by typing them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time she will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now we're pleased to present Dr. Bryann Bromley.
Hello, everybody. Thank you for joining me tonight. The topic that we're going to be talking about is the first trimester anatomic scan and our effort to screen for fetal anomalies at the 11 to 14 week gestational age window. Kathy went over our objectives, so for the sake of time, I'm not going to repeat them. We all know that the 11 to 14 week scan is much more than the assessment of the nuchal translucency alone. It's important for confirming or establishing dates. It's critical in the evaluation of multiples, specifically examining amnionicity and chorionicity, and it's important to look at the adnexa. However, the focus of this talk is how do we use the 11 to 14 week scan to look for fetal anomalies. Now, in 1998, our colleagues at the Royal Free Hospital in London reported on the successful visualization of a variety of anatomic features and the optimal gestational age to examine fetal anatomy. And you can see that the percentage of normal visualized anatomy increases from 11 weeks to 14 weeks, and that many of these structures we can see greater than 90% of the time once we hit 12 weeks gestation. Our ability to perform a successful fetal anatomic evaluation and measure the NT are shown in these blue categories, and you can see that this increases between 11 and 13 weeks. The need for transvaginal sonography, which is illustrated in pink, decreases with advancing gestational age. So the optimal time to perform an early anatomic survey is probably around 13 weeks gestation. First trimester practice parameters have been put forward by the International Society of Ultrasound and Obstetrics and Gynecology as a consensus of their clinical standards committee, and they really represent an international benchmark in first trimester fetal ultrasound. Like most practice parameters, Some items are considered compulsory or required. And during this presentation, they'll be highlighted by the 5-point star. Other items may be helpful in the evaluation of the fetus, but are not considered obligatory, such as the eye with the lenses. Still, other portions are limited to providers who have been appropriately credentialed, such as a nuchal translucency or nasal bone assessment. Now, when we do evaluate the fetus at any time in gestation, and specifically early in gestation, we want to keep in mind the ALARA principle, which, as you all recall, is the as low as reasonably achievable principle. So we want to make sure that we are scanning on a thermal index for bone at the lowest ratio possible to provide us with diagnostic quality images. And we can monitor this, by looking at our output display standard. Similarly, we want to make sure that we use a 2D video clip or an M mode to document fetal cardiac activity, and we really don't want to use Doppler unless clinically indicated. Cranial ossification should be evident by 11 weeks completed. This is optimally evaluated in either an axial or coronal plane, and what we should be looking for is the intact calvarium. We should be evaluating the fetal head to make sure that the sides are symmetrical and that the interhemispheric falx extends from the back of the brain all the way to the front of the brain. The brain mantle is quite thin at this gestational age, and so the echogenic choroids fill the lateral ventricles. These landmarks are all required parameters, as you can see by the star. Evaluation of the fetal neck is a key portion of the early anatomic examination. However, an NT, a precise NT measurement, is not required unless you're using it as part of a screening program for aneuploidy. If you are doing a nuchal translucency or nasal bone assessment, it should only be done by a credentialed provider in an ongoing monitoring program in a patient who has chosen first trimester screening for aneuploidy. As many of you do nuchal translucencies routinely, you're quite familiar with the mid-sagittal view that is required to get a reproducible nuchal translucency measurement and evaluate the nasal bone. You know that you have to look for the diencephalon. We have to be able to see the tip of the nose. The rectangular shaped palate should be identified without being interfered by the zygoma, and it should be contiguous. But what else can we see? We can look for the nasal bone, which makes an equal sign with the overlying skin edge. But also take time to look at the profile. Look at the chin. Is the chin small? Can we make a diagnosis of microcephaly? Look at the contour of the upper lip. Is it uniform and smooth? The palate should be echogenic and consistent throughout its length. What about the intracranial anatomy? We talked about looking at the diencephalon, but the other thing to focus on are the 3 brain spaces. We want to be able to make sure to see the brain stem. We can identify the 4th ventricle or intracranial lucency, and we want to look for the cisterna magna because these items may help us make a diagnosis of a spinal defect or other intracranial defect, posterior fossa defect, that otherwise might be quite elusive on an axial or coronal plane. Remember, however, that certain intracranial structures are not identifiable at this stage in gestation. Specifically, we're not able to look for the corpus callosum. We should look at the fetal face, look at the orbits. Where are they placed within the fetal face? We can see the lenses of the eyes. Look at the nose en face. You can see the retronasal triangle, and you can see the two paired nasal bones right looking at you. This is a different method for looking at the nasal bone. We need to look, or we can look, for the lips. You can see the outer skin edge being smooth and uniform. Look for the stomach in the left upper quadrant. This is a required component. And then rotate your transducer and you can see the diaphragm. And note that the stomach is below the diaphragm and the heart is above the diaphragm. We know that the stomach is in the left upper quadrant, and we've made this part of our imaging protocol, and it is a required component. So once we see the stomach, we can also look at the umbilical vein and recognize that it courses away from the stomach. And then we can look at our four-chamber view and make sure that our situs is correct. The kidneys are in their usual paraspinal location. Sometimes they're easy to identify, as in this fetus. Other times they're more elusive. We can turn on some color to make sure that we have renal arteries, always keeping in mind that we want to monitor our acoustic output or energy output by looking at our output display standard. And here you can see that we're scanning on a thermal index for bone, which is the proper thermal index at an acceptable ratio. The insertion of the umbilical cord into the anterior abdominal wall should always be visible and normal by 12 weeks gestation. And here you can see a normal cord insertion into the fetal abdomen. We can also look at the number of vessels in the cord by throwing on some color and counting them as they course around the bladder. The bladder itself is usually visible by 12 weeks gestation, although obviously it's physiologic and sometimes it empties. Evaluation of the thorax is a required component. We should look at the thorax in an axial scan, make sure that the shape of the thorax is normal, the shape of the ribs are normal, and that the lung fields are uniform and homogeneous, that there are no pleural effusions. We can see that the heart takes up about a third of the chest, and we should record its cardiac activity either by video clip or by M-mode. Now, one of the challenges is to look at the four-chamber view of the heart, but as you practice doing this, you'll see the four-chamber view in the majority of patients. And here you can see a sagittal four-chamber view of the heart and a more apical view. You can evaluate the cardiac axis, and we'll talk a little bit more about that later, but a normal cardiac axis is about 45 degrees. We can also see the outflow tracts. These are not requirements, but they're visible on most fetuses. You can see the left ventricular outflow tract and the right ventricular outflow tract. We can see a three-vessel view with the pulmonary artery, the aorta, and the superior vena cava. And we can look in a mid-sag view and we can see the inferior vena cava, the right atrium, and the superior vena cava. Evaluation of the spine is important, and we should look at the individual vertebral elements and see that they are properly aligned, and at the same time look at the continuity of the skin edge. The extremities need to be evaluated. This is a mandatory component, and they're often easier to see at this time in gestation than later on. The presence of each segment of the upper and lower extremities should be looked at, as well as the positions of the hands and feet. Here you can see the whole lower extremities with the little feet coming off at a correct angle. And here are two clips showing how you can see both upper extremities with a very quick sweep, and in this case, both lower extremities in a very quick sweep. Now I'm going to digress from the anatomic scan for 1 second, this single slide, because it's always a question that I'm asked when I give this talk, and that is placental location important at the 11 to 14 week scan? And the answer is no. While we should look at the size and the texture of the placenta, placental location in relation to the cervix is not predictive at this point in gestation. This is a transabdominal scan. You can see the cervix. You can see the placenta that's centrally located and completely covering the os, and you might be tempted to say, well, that may be true, but this one for sure is going to be a complete previa. But look at it at 18 weeks. The placenta has moved completely up, and the cervix is unencumbered by placenta. So placenta previa should be not reported at this stage. Now, how does the first trimester scan do in terms of detecting abnormalities? Well, the detection rate has been variable between multiple studies and has ranged from 18 to 76%. And why is that? When you look at the studies in the literature, they have very different inclusion criteria. Some involve high-risk patients, some are unselected patients. Some include those with karyotypic abnormalities, others only include those with normal karyotypes. There are different imaging protocols, what you have to look at, what you don't have to look at. There are different techniques. Some studies are done transabdominally only, some are done with both transabdominal and transvaginal imaging. There are different definitions of what is an anomaly. There are different confirmation criteria for anomalies that are suspected, different levels of expertise, and so on and so forth. But there is a recent study in the Green Journal by Rossi et al. That was a systematic review of the accuracy of ultrasonography at 11 to 14 weeks gestation to detect fetal structural abnormalities. And this study had strict inclusion criteria. The following structures had to be visualized as part of a protocol if the study was to be included in this systematic review. All abnormalities had to have a postnatal exam or pathology available. There were 19 studies that met this criteria with over 78,000 fetuses, of which almost 1,000 were abnormal, or 1.2%. And overall, about 50% of anomalies were detected, which is a figure that we tend to run with, that somewhere between 40 to 50% of anomalies can be detected at the 11 to 14 week scan when dedicated imaging protocol is used. Now, when we look for anomaly detection, the percentage of anomalies detected will vary depending on the organ system we're looking at. 92% of abnormalities of the neck are identified, and this makes perfect sense because it's one of the areas that we're used to looking at, especially when we're doing our nuchal translucency scan. And even without measuring the back of the neck in this fetus clearly has a very thickened nuchal translucency. Maybe it's a cystic hygroma, maybe there's total body lymphedema as it extends to the anterior abdominal wall. And so those type of abnormalities are clearly identified in the majority of cases. Abdominal wall defects, such as omphalocele, are also often identified, and here you can see this fetus, in addition to its thickened nuchal translucency, also has an abdominal wall defect, an omphalocele. Abnormalities of the brain and spine identified about 50% of the time. Cardiac abnormalities identified just under 50% of the time. And abnormalities of the limbs, the genitourinary system, and the face are identified about 1/3 of the time. Now, it turns out that we're better at detecting fetuses with multiple abnormalities than those with isolated abnormalities. We identify about 60% of those with multiple compared to 44% with an isolated abnormality. And that just makes sense because once you see one thing, you tend to go looking for other things. So this young fetus happens to have a not appropriately developed cranium. This fetus has acrania, and if you look around, you can see that there is a protrusion into the base of the umbilical cord. And then if you look at the hands, you notice that it looks like there are too many fingers. Throw on some 3D and you see that this fetus has polydactyly. And I would venture to say if you hadn't seen the acrania, you probably wouldn't have looked for other things. So certainly fetuses with multiple anomalies are more easily to identify. In the study by Rossa, and consistent with the earlier studies that I showed you initially, the anomaly detection rate increases between 13 and 14 weeks, and that's when it's maximum. The detection rate of anomalies is best done using both a transabdominal and transvaginal approach, and that approach is optimal when compared to just using transabdominal imaging alone or transvaginal imaging alone. Now, we see at the there are those which should almost always be detected, things like acrania, anencephaly, omphalocele. If we're doing a systematic evaluation, we really should not miss those unless imaging conditions are horrific, like multiple fibroids or other challenges that make us not able to see the fetus at all. Then there's a group of the intermediate group that are either likely to be seen, such as brain anomalies, and there are other things that are potentially seen, such as facial clefts. But this area is sort of wishy-washy because depending on your imaging conditions and the severity of what you're looking for, you may or may not see them. And then the last category are those things that we still cannot pick up at the 11 to 14 week scan, either because the organ is not completely developed, such as the corpus callosum, or things like pulmonary airway malformations that haven't even appeared yet. So there's certainly that category that we just can't see. Now, the first thing to think about are the things we should always see when doing the 11 to 14 week scan. Certainly there are abnormalities in external contour, such as limb body wall abnormalities. This is an axial scan through the fetal part where you can see that there is no recognizable architecture, and thin wispy line, which is a piece of an amniotic band that has disrupted this fetus. If you turn, you see you have two legs, but the whole wall and contour of the fetus is abnormal. And this type of anomaly should be readily apparent when doing your 11 to 14 week scan. Here are two fetuses, again, with contour abnormalities. In this case, in each of these fetuses, you can see that the heart is outside the chest. See the little hearts beating. There you go, one and the other. Since we're looking for the calvarium, and it should be complete by 11 weeks, we should be able to pick up almost all fetuses with anencephaly or acrania. Here you can see a sagittal view of the fetus, which is pretty normal up to the level of the eyes. And here you can see that the brain is freely floating within the amniotic space. This is another fetus, mid-sag view. And if you look at this fetus, the cranium is not well ossified. There's a big echolucent projection within the intracranial space, which should not be there. The slope of the forehead is abnormal. The whole head is too small. And those kinds of things should prompt your consideration that this fetus is not normal. Here's another fetus where you can see that the brain is cystic in appearance and freely floating within the amniotic cavity. This is a 3D reconstruction of that same fetus, a 3D rendering showing the lack of cranial development. When we look at the umbilical cord insertion, it is evident when it's abnormal. Here you can see a solid protrusion into the base of the umbilical cord. It's actually replacing the insertion. And if you turn on it, you can see this large liver-containing omphalocele. Sometimes they can be a little more subtle. Excuse me. You're measuring your crown rump length, and you can see this little projection into the base of the umbilical cord. And if you turn on it, you can see that the umbilical cord has this solid area, and this is a bowel-containing omphalocele. But there is a caution to this. Physiological herniations do occur. They begin about 8 weeks gestation, and they are most evident at 10 weeks gestation. The contents should have returned intracavitary by 12 weeks gestation. So here's a little fetus, and you can see the physiologic herniation clearly identified, but at 12 weeks, the anterior abdominal wall looks completely normal. So we have to be careful not to overcall an omphalocele. This is a fetus who came in for nuchal translucency evaluation, and in the process of doing the crown rump, you see this little bulge in the lower abdomen area. Turn transverse on it, and you can see that there's the umbilical cord insertion right here, noted in color, and there's a paramedian defect, which is irregular in nature and is not covered by a peritoneal covering in a gastroschisis. This fetus also came in for an early risk assessment. You can see that the NT was measured, the nasal bone is present, but as you look down the spine, you see this sort of unusual contour. What does that make you think of? This is a 12-week fetus. So the next thing we did was we went and we did a transvaginal scan. And here you can see that same mass, which appears to be coming off the lower end of the fetal spine buttock area. Throw some color on it, and it is a sacrococcygeal teratoma that you have identified in a young fetus based on the abnormal contour. If you had just done the nuchal translucency and the nasal bone and crown rump length, you wouldn't have seen it. But because you're following your systematic evaluation, you can make these type of diagnoses. Here's another fetus that came in for an early risk assessment. You can see the nuchal translucency, and it might be tempting to enlarge it and measure it and move on, but wait a second, you don't have any of your normal landmarks. The profile is abnormal. You can't even see the nose or the nasal bone. You have none of your intracranial landmarks identifiable. So what's going on with this fetus? As you look through the anatomy, you can see the cranium, but you don't see the falx, and you can't see symmetrical brain hemispheres. But you do see this echogenic projection within the head, and if you turn slightly, you'll see that there appears to be a defect in the bony skull. So what is this? Is it an encephalocele? Is it an intracranial hemorrhage? Is it a tumor? What's our next step? Well, throw on your color. Color is your friend. And if you put on the color, it is a very vascular structure, which tells us that it is certainly not going to be a hemorrhage. And this, in fact, was an intracranial teratoma that was growing out of the fetal brain and disrupting the face. It's surprising to me that limb anomalies were only detected about 34% of the time in the studies included in the Rossi review, because they seem to be easily identifiable at the 11 to 14 week scan. Here you can see a fetus. You can see one normal leg, and this leg is clearly abnormal. It's truncated mid-thigh. Or this fetus in an axial scan through the fetal chest, you can see an upper extremity, one segment, the proximal segment is normal, but the second segment is missing, and the hand is coming off at an unusual angle. This fetus had a radial ray defect. Here's another fetus with an abnormal leg. The three segments are not identifiable, and if you do a 3D rendering, you can see one normal leg and one very abnormal leg. The other thing you want to do when you're looking at the limbs is make sure that the lower extremities move apart from each other, that the kid can kick. If the lower extremities are fused, you've made the diagnosis of serinomelia. And this will be the optimal time to make that diagnosis because serinomelia is often associated with abnormalities in the kidneys, renal agenesis, or otherwise dysfunctional kidneys, which will result in oligohydramnios and make visualization very difficult. But at 11 to 14 weeks, the amniotic fluid is still mostly a transidate, so that the absence of kidneys does not really compound visualization because you still have fluid to help you see. Some limb abnormalities are major, but they may be more difficult to see. For example, this fetus where you can see the upper segment, the lower segment, the radius and ulna, and the only thing that catches your eye is maybe you don't see the fingers as well as you'd like to. Maybe the hand is a little small. And if you throw on your 3D, you can see this fetus had one normal hand and a transverse amputation defect for the other. This fetus was referred for a scan at 12 weeks, but was not planning on pursuing prenatal diagnosis, as she said she would not act on a positive result. The neck region was normal, the nuchal translucency was normal, the nasal bone was present, but one of my sonographers came out and said, the limbs look really stubby. And so we thought, wow, what does that mean at 12 weeks? So we went back in, and it was apparent that even though there's limited normative data for femur length at that gestational age, that the femur was short and it was bowed, and the limbs really did look quite foreshortened, especially compared to what a normal fetus at that same gestational age would look like. And this fetus was suspected initially of having a skeletal dysplasia and was asked back at 16 weeks. However, she came back at 13 weeks. The findings were unchanged, which was compounded by the short interval of observation, and the patient elected to terminate her pregnancy without waiting for traditional confirmation. And I bring this up to you because patients will often have a passionate response to anything you say at this time. And so I share it to be wary that sometimes people do not wait to have the full answer. The pathology on this case was consistent with anatophoric dwarfism. So fetus who came in, and in evaluating the extremities, you can see that the hands are abnormal. There's ectrodactyly. You can see what has been classically called a lobster claw deformity. Similarly, the feet were abnormal. You can see the abnormal configuration of the toes. Looking further through the fetus, this fetus has micronathia and was suspected of having ectrodactyly ectodermal dysplasia cleft syndrome, and terminated the pregnancy based on these findings. Another thing that you should almost always be able to identify at the 11 to 14 week scan is alobar holoprosencephaly. As you look through the axial scan through the fetal head, you can see that there's clearly a monoventricle and fused thalami. Same here. You don't have to wait to 15, 16 weeks to make this diagnosis. If you see a fused a fused thalami and a monoventricle even as early as 11 weeks. That fetus has a lobar holoprosencephaly. Here's a fetus with, as you can see from our recent discussion, a lobar holoprosencephaly. You can see the monoventricle, the fused thalami. This one has some cystic hygroma in the nuchal region. And this is what it looked like on sagittal view. This is not just a bad picture of the profile. This fetus did not have an identifiable profile. It had a very, very flat face. And if you do 3D, you can see that it had postaxial polydactyly. So the combination of a lobar holoprosencephaly, abnormal face, postaxial polydactyly, really leads you to the diagnosis of trisomy 13, which was confirmed after termination. This fetus came in also for a first trimester risk assessment, and we were having trouble getting the nuchal translucency because the baby was not in a perfect position, but that seems to happen not infrequently. And my sonographer, who is very astute, noticed that there was this little structure behind the fetal head. We weren't sure if it was the yolk sac or if it was something else. The lady was of a higher BMI, as you can tell by the images. And so our next step was to go and use our transvaginal scan. And on transvaginal sonography, you can see clearly that this fetus had an encephalocele. Here's another fetus. At approximately 12 weeks gestation, this axial scan through the fetal head, the posterior fossa appears abnormal, but we're always a little bit nudgy about that early on. However, if you look in the sagittal view, that posterior fossa is clearly abnormal, and you can see the fetus does have an encephalocele. Is that enough? What else can you do? Well, it's worth your while to look around. You can see by examining the extremities that this fetus also had postaxial polydactyly, and the kidneys were cystic and echogenic. This fetus had Meckel-Gruber syndrome, which is important in order to discuss recurrent risks. Spinal abnormalities can sometimes be seen in this fetus. You can see that the vertebral elements are kinked and that the lower spine is clearly abnormal. They're a splaying of the vertebral elements, but they're not always so obvious. So Dr. Chowie has recommended looking at the intracranial lucency. You're used to the mid-sagittal view. We talked about the three brain structures. We talked about the brain stem, and we talked about the intracranial lucency or fourth ventricle and the future cisterna magna. In fetuses with open spina bifida, there is displacement of the brainstem and compression of the IT or fourth ventricle and cisterna magna, so that the intracranial anatomy is abnormal. And this is a fetus who was later shown to have spina bifida. You can see that the thalamus and midbrain and brainstem are posteriorly displaced, and that you don't see an intracranial lucency or the cisterna magna. Now, Mangione et al. Looked at this in a retrospective study. They had 4 reviewers look at these 3 features in 52 cases of open spina bifida and 208 controls. And here you can see the different structures that were visualized or attempted to be visualized, and their absence or abnormality was shown to be able to be sensitive for the detection of open spina bifida between 30 and 80%. However, the false positive rate was 1 to 12%. If you looked at one or more of findings, 50 to 90% of fetuses with spina bifida were identified with a false positive as high as 9 to 20%. Further prospective studies are being conducted, and there's a recent study by Chen et al., a prospective trial looking at this that you can look at if you are interested in further information. Further studies need to be done to see what the clinical utility is of this. But I think that the take-home message to me is that a normal IT has a high specificity for excluding spina bifida. We want to look at the posterior fossa. We want to look at those 3 intracranial lucencies, and here you can see there's an abnormality. Had we noticed this when we were doing this nuchal translucency assessment, we might have had the patient return earlier. However, this is several years old, and it was before we were looking at intracranial lucency, and the patient came back at 20 weeks, and you can see clearly an abnormal cerebellum. The hemispheres are splayed apart, and there is a big posterior fossa cyst. That might have been identified earlier on had we really known to look at the intracranial contents. Here's a fetus with a nice intracranial anatomy, but looking down the spine, you can see that this fetus has fused hemivertebra. We can look for heterotaxy syndrome. Remember, we were looking where the location of the stomach was in the heart. Here you can see the stomach is on the right and the heart is on the left. We can make that diagnosis at 11 to 14 weeks. Certainly, we should be looking for a 4-chamber view of the heart, and I'm not going to go into the heart in detail because hopefully there will be another presentation on congenital heart defects in the first trimester at the 11 to 14 week scan. But you can all see that this is a normal looking heart compared to this heart where you have a distended right atrium. This fetus had an Epstein's anomaly. If the heart looks not symmetrical, throw on some color. This fetus had a small left ventricle and a pericardial effusion. If you throw on some color, you can see that color only fills one side of the heart in a functional hypoplastic left heart. Now, the cardiac axis has been shown to be helpful in identifying fetuses with congenital heart defects. The normal axis ranges from 30 to 60 degrees. And if you use the cardiac axis, 74% of fetuses with congenital heart defects will have an abnormal cardiac axis. 56% of them will have a left axis deviation. 9.6% will have a right axis deviation. And then there's a certain percentage where the cardiac defect is so significant you can't really determine axis. And here's an example of a fetus where the cardiac axis is 90 degrees, clearly abnormal. And as you look at the outflow tract, you can see an overriding aorta. This is an example of a fetus with tetralogy of Fallot at 14 weeks gestation. Well, facial clefts are also fairly elusive at the 11 to 14 week scan. We have been relying on the maxillary protuberance here to help us in identifying a fetus with a facial cleft or this fetus with a sloping forehead and an abnormal mid-face. But is there anything else we can do to look for facial clefts? Well, this fetus had an abnormal lower profile, and when it came back at 18 weeks, you can clearly see that it had a large facial cleft. However, with 20/20 hindsight, we can look back and say, wow, the maxilla on this fetus is abnormal. There is a gap. In fact, the whole front is missing. You can only see this little structure here. So the maxillary gap has been proposed as a first trimester marker for cleft lip and palate. Dr. Chowie did a retrospective study on 86 patients with cleft lip and palate and compared it to 86 controls. And what he looked at was the maxillary gap. There were 49 patients in this study that had cleft lip and palate with other anomalies and 37 with isolated cleft lip and palate. And in retrospective review, 96% of those with other anomalies had a maxillary gap, and 65% with isolated cleft lip had a maxillary gap. This enabled the prenatal diagnosis of facial cleft in 93% of fetuses where it was not isolated within the first trimester, and in 24% of those with an isolated cleft lip and palate in the first trimester. However, the false positive rate was 7%. In order to improve this, he defined the maxillary gap as being 1.5 millimeters or greater, and that identified still a substantial portion of fetuses with facial clefts, but no normal fetuses had a maxillary gap of larger than 1.5 millimeters. And this study included all comers, so that there were certainly fetuses with abnormal karyotypes in this population. And this is the example, this is the follow-up at 18 weeks of this fetus with that small maxillary gap. Here's another fetus that came in for a nuchal translucency nasal bone assessment. You can see the nuchal translucency is normal. The nasal bone looked present. The maxilla looked intact. And the baby came back at 18 weeks and clearly had a cleft lip and palate. But looking back through the images, there was an image, there were several images, and where the maxillary gap was apparent. So you have to really scan through the whole maxilla, both sides, in order to know whether there is a gap. Here's another fetus who came in recently with a negative cell-free DNA testing for an early anatomic scan. You can see the maxillary protrusion here. You can see the maxillary gap. This is what it looked like on live scanning. And this is the 18-week survey for this fetus with a bilateral facial cleft. Prospective studies are still needed to assess the clinical utility of this finding. We look at the chin. Clearly this chin is too small, as is this one. Cases of micrognathia. We talked about looking at the position of the eyes within the face. This fetus has hypotelarism. But what about this baby? You're going to, come in for your nuchal translucency. You'd like to measure it. But what's this? What is this cystic space here? If you go transverse, you can see that the cystic space is within the abdomen. The cystic space is elongated. And here you can see the fetal heart. This is a congenital diaphragmatic hernia at 12 weeks gestation. We can see dilated bladders early on. In this case, you can see a hole from a lower urinary tract obstruction in a fetus with posterior urethral valves. The kidneys are already echogenic and somewhat cystic and abnormal in appearance. But again, the amniotic fluid volume is normal because most amniotic fluid at this stage is still a transidate. But I caution you that not all big bladders at the time of the 11 to 14 week scan are abnormal. Megacystis is defined as a bladder of greater than or equal to 7 millimeters and certainly has been associated with aneuploidy. However, in those that are euploid, the enlarged bladder resolves itself most of the time. And in this particular fetus, we were concerned, clearly had megacystis. You can see almost 13 millimeters, very large bladder, had a normal screen, had a normal amnio, and you can see at the time of a follow-up survey, the bladder is completely normal and this fetus had no genitourinary problems. This is a fetus who came in with a negative cell-free DNA, and when asked to do an early anatomic survey, we thought, wow, this baby's only about 11 weeks, 10 and a half, 11. It's too early, come back in a week. But take a good look at this fetus because this is a really important learning point. She came back in a week, and what you can see is clearly a fetus has a very large head, small body. This is asymmetric growth restriction and is classic for triploidy. So if you have a fetus that you suspect is size less than dates and has asymmetric growth restriction and anomalies, think about triploidy. Triploidy will not show up on most standard cell-free DNA, and you really need a SNP-based cell-free DNA screen in order to pick it up. Now, there's certainly malformations that are not detectable at the time of the 11 to 14-week scan. This fetus has agenesis of the corpus callosum. You can see the colpocephaly, the parallel ventricles, but at 11 to 14 weeks, the intracranial anatomy looks perfectly normal for stage. This is a fetus with a congenital pulmonary airway malformation. Again, nothing seen early on, but this developed later, so you're not going to see it in the first trimester. And similarly, many gastrointestinal abnormalities develop in the later third trimester. This fetus has an obstruction that was not seen either at its 11 to 14-week scan or at its 18-week survey. Now, it's important to remember that the first trimester anatomic scan does not replace the second trimester scan. While we do pick up roughly 50% of abnormalities in the first trimester, there's an additional pickup in the second trimester, so that overall our prenatal detection rate may approach 90%. However, you can't give up the second trimester scan. What are the benefits of an early anatomic scan? The early identification of abnormalities, this fetus with a large cystic mass within its lower abdomen, which turned out to be the fetal bladder. This fetus had a bladder outlet obstruction, again with normal amniotic fluid because it was so young that amniotic fluid was not dependent on fetal urine production. Early diagnosis also allows us earlier options for counseling and diagnostic testing. Early options for involvement of specialist care, and early options for termination of pregnancy in the patient who desires to do so. The risk, however, of the early anatomic scan is that there is some unknown natural history of findings and that people will sometimes act on a positive result before obtaining complete information. This fetus came in for a nuchal translucency assessment. The nuchal translucency was normal. The nasal bone was present, but we noticed that there was scoliosis, and this patient opted to terminate before having any other evaluation. Now, early anatomic imaging is relatively new in the United States, and our group experience is not extensive. And most importantly, there have not been good studies looking at costs and resource allocation and outcome. How does this change outcome? But certainly for the patient who is reassured by early imaging, this can be a very helpful and useful process. So I thank you for your time tonight, and I'm happy to entertain any questions. I'm hoping that you feel comfortable just sort of differentiating this fetus from this fetus, and that you feel comfortable counseling the patients concerning that. So I'm going to try answer these questions. The first question is, do you do a full anatomy scan at the time of your NT screen? Yes, we do an early anatomic scan on all patients that come in for a nuchal translucency scan. Does insurance cover the early anatomy scan? Not usually, no, unfortunately. Do you recommend transvaginal and transabdominal at the time of the NT screen? In our practice, we always start out transabdominally, and if there's something we can't see or something that concerns us, we do go on to transvaginal scanning, but we only do that based on what we see or don't see transabdominally. So we're very liberal in our use of transvaginal scan, but it is not required. If we see everything transabdominally and we feel good about the quality of our imaging, then we do not feel it is necessary to do a transvaginal scan. Having said that, in a study that we published in JUM, approximately 10% of our cases overall had transvaginal scans. However, 75% of those in which anomalies were detected had transvaginal scans. So we use it when we either can't see or if we see something that's suspicious. At what age can you see the corpus callosum? That's a good question. You certainly can't see it at 11 to 14 weeks. The cavum septa pellucidity is the proxy for the corpus callosum, and we should be seeing that at approximately 15 weeks gestation, which for practical purposes excludes most cases of complete agenesis callosum. If you're really looking at the corpus callosum itself and not the cavum septum as a proxy, my understanding it is not totally complete until 22 weeks, although in some cases you will see it earlier at the time of your 18-week survey. I don't see any other questions, so I hope everybody has a great night. I am hoping, to do another one of these talks in the not so distant future. Sorry, this just went off on me. And the talk planning to present to you in the future is one that entails looking at the first trimester anatomic scan and determining whether it is useful and what additional information is available.
Thank you so much, Dr. Bromley. You see another one?
There's one more question. I'm sorry. What about safety concerns for ultrasound in the first trimester? That's an excellent question, and it is incumbent on all of us to practice in compliance with ALARA, in which case, sorry, I'm just trying to show you my slide, but it's not coming back up, so that's gone. I think the important thing for us to do is to make sure that we are scanning on a thermal index for bone at this gestational age, and that our ratio for thermal output is as low as can be used to obtain diagnostic quality images. I think if you need to use color Doppler to help with your diagnoses, that is appropriate as long as you keep track of the energy output. Duplex Doppler should not be used unless clinically indicated.
Okay, well, Dr. Bromley, thank you so much for this this wonderful lecture, and we will look forward to the next section of it. Thanks to everybody who participated tonight. Everyone, please remember to complete the post-test and the activity evaluation. We hope you enjoyed this evening's presentation and will join us again for future webinars. Good night, everyone. Have a great evening.